Good afternoon, everyone. My name is Jenny Rank, and I'm the CGNE Education Program Specialist. We also have Amy Caputo on with us today, CGNE Marketing and Communication Specialist, to help out with this session. It's my pleasure to serve as a facilitator today for our final CGNE seminar of our fall series. On behalf of our team, thank you for joining us today. This program is being provided by the Teresa Meese and Helen Diskovich Center of Geriatric Nursing Excellence at the Penn State Ross and Carol Meese College of Nursing, in collaboration with the Office of Outreach and Professional Development, the Center for Nursing Research, and Age-Friendly Care PA. Today's seminar, Integrating Age-Friendly Care into Primary Care and Long-Term Care, the 4Ms Framework, will be presented by two of our center's very own, Dr. Erin Kitt-Lewis, CGNE Associate Director for Education, and Jenny Knecht-Fredo, CGNE Graduate PhD Student Affiliate. Before we begin, we have some disclosures and announcements. Penn State Ross and Carol Meese College of Nursing is approved as a provider of nursing continuing professional development by Pennsylvania State Nurses Association, an accredited approver by the American Nurses Credentialing Centers Commission on Accreditation. Participants with a valid RN license who attend the entire Nursing Continuing Professional Development Program can earn 1 contact hour. Partial contact hours are not awarded. The topic of this education is non-clinical, and therefore we do not identify, mitigate, or disclose financial relationships. As a reminder, this seminar is being recorded, and questions will be addressed in the Q&A part of the session after Jenny and Erin present. You can either enter your questions into the chat, or you can use the raise hand feature and we will unmute you. The post-event evaluation survey link will show up in your browser once the session ended, and it will also be emailed to you within 24 hours. And while it's required for RNs, we ask that all attendees complete the evaluation to assist with data collection. For RNs, Zoom in and out times will be recorded, and you'll be required to complete that post-event evaluation survey, and your certificate will be emailed to you within 1 month following the seminar. Now, I would like to introduce Pauline Huang, who will read the bios of our 2 presenters. And Pauline Huang is not only one of our CGNE affiliate graduate students who is studying post-stroke cognitive impairment, but she's also one of our valued GERO faculty members. And she's been really instrumental in her GERO classes have provided students for our memory cafes for living with dementia in the past. And it's been great to collaborate with you. So thank you, Pauline.
Thank you, Jenny. So I will introduce Dr. Erin Kitt-Lewis. She's an associate professor at the Penn State Ross and Carol Meese College of Nursing. Alongside her teaching and clinical practice, she's an active researcher dedicated to educating nurses and healthcare professionals in caring for older adults, individuals with chronic conditions, and those at the end of life. So one of her research projects focuses on creating age-friendly healthcare system in nursing home facilities. Currently, she serves as the faculty for Teaching Nursing Home Collaborative, where she fosters and strengthens partnership between the college and nursing home facilities to promote age-friendly care, person-centered care. The next person, Jenny Knecht-Fredo. She's a certified registered nurse practitioner with a dual master's degree in family nurse practitioner and nursing education, and is currently pursuing her PhD. She continues to practice serving older adults and their families by managing care at the local memory care facility and spend the majority of her time working as an educator for age-friendly healthcare system and resource coordinator for long-term care RISE program. Jenny's passion lies in translating science to empower clinicians and implementing quality improvement initiatives to drive better health outcomes and enhance the satisfaction for both patients and clinicians. Thank you.
Hello, all. I'm so excited to be here to be presenting alongside Erin. I'm going to pop the slides up here and then we'll get started. All right, quick thumbs up. Can everyone see these? I'm assuming yes. Okay, so the title of our presentation is Integrating Age-Friendly Care into Primary and Long-Term Care Settings. And we are going to start with a quick maybe get to know you, figure out what you guys already know or think about age-friendly care. So if you guys could put in the chat, type maybe one word, a quick sentence, or a few words to answer the simple question, what does age-friendly care mean to you? And I'm going to give it about 2 minutes here, and we'll see what kind of answers we get. Okay, so let's see what we're getting here. Honoring preferences, providing equitable care, appropriate, easy access. Ooh, girl, everyone here, good answers. Dignity, accommodating the older adults' needs and wants, giving care where they are emotionally, personalized, individualized, equitable. Wow, good job, guys. Everybody is putting some really great answers in here. So I thought that this picture was pretty neat. It shows a lot of the answers that you guys already put in the chat. So empowering, individualized care. And I love that the center of this picture shows equity, because I really do think the age-friendly health system model is a way to ensure equity for older adults. But it also does all these other things as well, right? Honoring autonomy, person-centered care, joy, like it does so much. So let's talk a little bit about it. So by 2060 in the United States, the number of Americans over the age of 65 is expected to double from roughly 50 million to nearly 100 million. As the population ages, there are many factors that are going to impact the care that we are able to provide older adults. So some of that could be just demography, just simply the number of older adults that there are going to be in the United States is going to be a large amount. How are we going to be able to provide great care to a large amount of older adults? There's also the complexity component. So approximately 80% of older adults have at least one chronic disease and 77% have two. And then there's disproportionate harm. So older adults have higher rates of healthcare utilization as compared to other age groups, and they experience higher rates of health-related harm, delay, and discoordination of care, sometimes just because they are in the health system more frequently. So although the United States is currently ranked in the top countries in the world for care for older adults, there's significant variations across the country in regards to access to quality of healthcare and then quality of life as well. So although there are these evidence-based care models that have been proven to be very effective, many of the care models do not reach who could benefit the most. And it's because some of these care models can be difficult to disseminate and scale, difficult to reproduce in settings with less resources, and so on and so forth. So the age-friendly health system was thought up, created, developed as really not necessarily just another check mark thing to do for older adults, but really as a social movement. It's guided by a set of evidence-based geriatric practice interventions, and these are known as the 4 M's. So if you've heard of the 4 M's, you already know about age-friendly health systems. The 4 M's are what matters: medication, mind, or mentation, and then mobility. And we'll talk a little bit more about these as we go through the presentation. So the age-friendly health system mission is to build a movement so that all care that all older adults receive is age-friendly care. This can be care in the acute setting, care in the primary care setting, care at a physical therapy office, care anywhere that an older adult is receiving care. We want it to be age-friendly. The parts of age-friendly goals are it causes no harm as well, it's guided by the 4 M's, and it's consistent with what matters to the older adults and their families. So using this system, value can be optimized for all. So value for the patients, the caregivers, but also for the healthcare providers and the health systems. And I like to talk right now a little bit about why the 4 M's. So why did age-friendly health systems pick the 4 M's as the main, components of age-friendly health systems? So the 4 M's, what matters, mentation, mobility, and medication, represents core health issues for older adults. All 4 of the M's build on a real strong evidence base already. By focusing on each of the 4 M's, it simplifies and reduces implementation and measurement burden on systems while simultaneously increasing effect. So we know most primary cares and most acute care centers are focusing on all of these M's anyways when they're providing care. But it's the key of doing it all together that can really increase the effect of quality of care that we're going to be providing. And the components of the 4 M's are synergistic. So if we are looking at the medications and we're taking away medications that can cause harm, we're going to increase their mobility and increase their mentation and so on and so forth. So they're really synergistic in nature. So the age-friendly health system movement is focused on health equity. It focuses on improving the quality of life of older adults by making healthcare systems and environments more accessible and really more responsive to the unique needs of older adults. And it promotes equity by ensuring that older adults, regardless of their health, their income, their background, that they receive the comprehensive, respectful, and accessible care that allows them to live healthier and more fulfilling lives. So I'm going to talk specifically to implementation of age-friendly health systems in the primary care setting, and then Erin will talk a little more in depth in long-term care, which is really great. So the data that I'm going to share is about the primary health network. So they are the largest FQHC in Pennsylvania and one of the largest in the nation. They serve over 70,000 patients in 2021, I'm sorry, and 50% of their population fall under the 100% federal poverty level. So we worked alongside them and collaborated with them for 5 years during the Geriatric Workforce Enhancement Program, also known as the GWEP, if you ever heard of that. Initially, we started by engaging 3 of their pilot sites, and by the end of our time with them, we were able to get 23 of their sites, which are all the little black dots on this picture, age-friendly certified sites. So I want to start by saying there were really 2 things. Our biggest wins came from small changes and PDSA cycles. So a PDSA is a Plan, Do, Study, Act cycle. It's continuous. And those were the ways that we were able to make the biggest changes with the primary health network. The other thing that really made differences were we focused on things that already mattered to them. So they were already really focused on a big mobility initiative. And since we knew that they were already focused on mobility, we really used that to then do some quality improvement projects that really also aligned with what the other mobility initiative they were already doing. And that allowed us to really make some great progress. But one of the first PDSA things that we did with them, PDSA cycles, was we looked at the cognitive assessment and we looked in their EMR. We realized after looking at 5 AWV visits that not a single one of those visits had a mini cog completed. So each one of those visits, they had documented no evidence of cognitive impairment based upon direct observation. So we went back and we realized even though we had implemented the mini cog into their EMR and had it really ready for them to do, they still weren't utilizing the mini cog. So we actually did not need to change the EMR at all. We had really great in-depth education sessions with all of their AWV nurses that really focused on how to use the mini cog and why assessing cognition was important. So we did no EMR changes. We just focused on education. And then in the next PDSA cycle, all 5 older adults that we looked at in their AWVs had a documented mini cog assessment. The addition of the 4M worksheet was also a real big game changer for us. We really designed this worksheet to put the 4Ms into the older adults' hands during the AWV visits, but also at future visits. They could use it whenever. We laminated the worksheets. The older adults were able to fill it out. They used dry erase markers, and they were able to change their answers as their life progressed or as something changed in their life. It was a way to not only involve older adults in the framework, but also to empower them to use the 4Ms in their own care and have something with them to remind the providers to use the 4Ms. Currently, this sheet is used all across the nation, actually. Annual wellness nurses are using it, community health workers are using it, different local areas of aging in Pennsylvania, emergency rooms are using it. And we did also create a nursing home 4Ms worksheet that I know Erin's going to talk a little bit about as we go through as well. You can get these 2 worksheets on agefriendlycare.pa.psu.edu. I will put that in the chat. I'm going to pass the baton over to Erin. Oh, you're muted.
You think we would know by now. So thanks, Jenny. I'm going to be talking about how age-friendly care was implemented into long-term care. So next slide, Jenny. So the study that this was done through with Penn State and a partnering nursing home is called the Teaching Nursing Home Collaborative. And if you're not familiar with this, the goal of this collaborative is to transform nursing education, enrich residents' care, and support the nursing home workforce. And how we do this is to try to get undergraduate nursing students excited about their experience in long-term care. So this means getting them more exposure and getting them more exposure in a really positive way so they could see themselves potentially working in the long-term care facilities. We're able to provide support with our practice partners, which is the nursing home, and the academic partners can offer things like expertise using age-friendly care and incorporating that into the nursing homes. And then also work as part of the Teaching Nursing Home Collaborative, we're collecting and gathering resources and creating sort of a repository so that the nursing homes or anyone else that would want to do this, other schools of nursing, other nursing homes, are able to see what we've done. And if they would want to take any piece of the project, for instance, Jenny had talked about the age-friendly care worksheets. We are using them here at Penn State, and so they are in the repository and people can pull them off and use them if they would want to use them at either their nursing facility or if perhaps an instructor would want to use them with their students for a clinical assignment. And our implementation of Teaching Nursing Home Collaborative is really focusing on the age-friendly care health systems or the 4Ms framework. Next slide. And so this is just a picture of the people that started the collaborative. And you might see some familiar faces on there. Ann Kolanowski, I can see her pretty clearly. And next slide, Jenny. And the Teaching Nursing Home Collaborative is funded by several partners. It's the Jewish Healthcare Foundation, the John A. Hartford Center, and some other sponsors as well. And at University Park, We decided to partner with Center Care, mostly because we were already taking students in our undergraduate program there. And so they were willing to have us and willing to join the collaborative as well. And they are 10 minutes from the University Park campus. They have 240 beds. They're a nonprofit, and a majority of their residents are Medicaid. We initially started with Andrew Noggle, who's the administrator, and he led the project for the first year. And then Felicia Heaton, the assistant administrator, took over, and now I collaborate with her pretty closely. Next slide, Jenny. And so Center Care has many opportunities for the students. They're high tech, high touch. They offer direct care so the students can get in there and, practice in the fundamentals class with the ADLs and other skills like communication that are important and new to the students at that level. They have several registered nursing roles there, including the nurse manager, the RN assessment coordinator, the staff development coordinator, and they also have an in-house nurse practitioner that works with the medical director, and they both are employed by the facility. So students can even see some advanced care practice there as well. Oh, sorry, can you go back? They have the one unique thing about Center Care, they do have dementia care and a rehab unit, bariatrics, and community health, but they also have a dialysis unit, which is pretty unique to most long-term care facilities. So students can go down, if their clinical happens to be on a dialysis day, which is Monday, Wednesday, Friday, they're able to go down and see that as well. Next slide. So when we partnered with Center Care, I'm sure everybody, can acknowledge some of the burden that staff face there. Not enough hours in the day, as many of us feel, to get the work done that needs done. And so we didn't want to bring a project in and create additional burden to the staff or even the residents. And so we tried to create a partnership that was mutually beneficial. So we looked at what their needs were, what the needs were for our students, and we wanted to make sure that it was a good fit. And then anything that we tried to implement was done in a very efficient and productive way, and was always driven by the data or outcomes for the residents and the students. Next slide. And so this took a lot of planning and preparation to get this started, because again, we wanted to roll it out and we wanted to be, have a pretty seamless rollout. So people would, as we gained awareness or rose awareness about the project and gained enthusiasm, we wanted to make sure that that enthusiasm continued. And I wasn't part of this for the first year, but I'll just share a little bit about what was done. They had to kind of see where they started and, the partnership that they already had between Penn State and Center Care, and look for new opportunities that we could expand that collaboration. And we also wanted to look at the goals of Center Care and also the goals of our students, because sometimes, especially in the early clinicals, we can become very task-oriented with students, and we didn't want the staff to think that they were just there to do ADLs. We wanted them to learn other things beyond just doing direct care and ADLs. So critical thinking, working on their communication, and even collaborating with the nurses to kind of see what could be done. And then Center Care, of course, had to get board approval, and they started to develop their team with Andrew Noggle, the administrator, at the lead. In Penn State, as I said, we were already taking students there for 230 and 310, but we did actually start taking more students with increasing the number of clinicals that went there. And then we also looked at some advanced practice opportunities, and initially it was a different person, but when I stepped in, I served as that role and was the liaison between the facility and Penn State. And then we introduced the 4 M's to the facility, and we did that a couple of ways, not only with Center Care, but also with the students and the faculty that teach for Penn State. Next slide, Jenny. So here's the people that we kind of tapped initially to help. These are all people who have expertise in gerontology, dementia, delirium, care of the older adults, specifically in nursing homes, or helped work on the age-friendly care PA. And as you can see, Jenny was one of those folks. Next slide. And so what we did was build to try to raise awareness around this collaborative, was do some virtual and in-person trainings at the facility. Andrew Noggle did require it for their staff. And then I did some subsequent trainings literally on the units between shifts. I would try to catch as many people as I could. I would do it in less than 15 minutes and give them a one-page handout to kind of reinforce what we talked about. And when I did those trainings, I really focused on just 1M each time. So it could be kept very short and sweet, and, kind of ask them, what did you already learn, or what do you remember about your initial 4M's training, and kind of gauge where each person was at. Or sometimes I had 2 people in a group, but that I think was really helpful because, many said, yeah, I remember that, but I haven't been applying it. So, this refresher was nice. We just didn't train the staff at Center Care, but we also talked to the residents and their families and told them about the project and raised our awareness that way too. And residents and families also participated in a focus group related to this. We started rolling out the 4M's worksheet that Jenny had pointed out. And so a lot of the residents were able to see it in action then. And we did get some feedback from them as well. And one of the residents said, I never really thought about, and I'm paraphrasing here, thinking about what matters to me. And so you asked that question several times in several different ways. And now it's like, okay, what does really matter to me? What is important to me? And what can we do to see that, come to fruition? And then the other thing we used were the age-friendly care modules, which it's called Age-Friendly Care PA. And Jenny is gonna, I think, post that website. But it's available to anybody. It's free. They have 2 tracks. It is both for healthcare providers as well as for residents, older adults, and their families. Next slide. Up in here, I have the website on here and I forgot. And the Age-Friendly Care PA modules were made in collaboration with Penn State, Ross and Carroll Neese College of Nursing, and the Penn State Teresa Neese and Helen Diskovich Center of Geriatric Nursing Excellence. And I always feel like I have to say the whole title because I'm very thankful for the support of the Neeses. And then also the Primary Health Network. And there's the online modules, like I said, are for both healthcare professionals. So anybody can take them, they're free. And they have little resources on there. As Jenny said, the 4M's worksheet is there as well. And this was disseminated through GWEP. Go ahead, Jenny.
And you also can earn free CEUs or free contact hours if you're an RN. So
that's another bonus. Okay, next slide. And so a couple of things that the academic partners did was we looked at our 310 class, which is care of the older adult, and 230. And I just provided some context there, looking at, we have 80 hours of didactic and 45 for nursing 310. And then for nursing 230, which is the fundamentals course, we have 80 hours of didactic and 90 hours of clinical. So students are in long-term care just in these 2 courses for about 135 hours, which is really, I think, a great service to them and to people who are living in nursing homes. And again, we oriented the faculty and the students on the Teaching Nursing Home Collaborative. And then what's really nice about Center Care is Andrew Noggle does their new student orientation, or it's, to make sure that they understand what's expected of them when they're at Center Care. And he does a great job. And I'm sure Marie Yoder, I saw, was on the call. can really attest to how he demonstrates to the students, like, you need to treat these people as if they're your own family. And he sets the bar very high, and does it in a great sort of caring way, and really demonstrates to the students that he really wants them there and he thinks that they're a benefit to his facility. And then we also have the age-friendly care modules that they complete. Next slide. The other thing that's really helpful in working in this collaboration between academic partners and nursing homes is to make sure that you stay on task. We really can get bogged down with the busyness. So when I started on the project, I was having weekly meetings, and this was with not only the leadership from the teaching nursing home, such as Marie Boltz, Donna Fick, and Maureen Saxon-Goya, who works at the Jewish Healthcare Foundation, but also any faculty that could come, and a representative, at least one representative from Center Care. And we just really talked about announcements, what's been going on, what we've accomplished, any barriers or challenges. And as you can imagine, mostly that was time for everyone, especially Center Care staff. And then what we were going to do to kind of overcome those challenges. And then the next, item that we were going to tackle as part of our goals or objectives. And we've really come a long way. And I do really think these meetings helped and were beneficial, especially during that first year. Next. And so I kind of already mentioned this a little bit, but we did have that annual or that initial kickoff. And, it was an all-day in-service, all the staff, not just nursing. This was all staff throughout the whole Center Care had to attend, and really were oriented to age-friendly care. And that's the 4 M's specifically. And then again, as I said, I did subsequent trainings with our students. There was training on delirium screenings for the residents with student participation. We had on-unit huddles, and those brief 1-page information that they could take with them and to help reinforce the content. Next slide. So initially I was on site at least 2 times a week, sometimes more. And then I was able to kind of scale back to 1 time per week. And as I mentioned, these are just some of the activities that we did to work and support our partners. And, we started with this initial rounding with students and the CNA and the LPN on the floor. Sometimes we pull restorative nursing in, and we've really expanded now where the medical team, including the medical director and Z, who is their nurse practitioner, Z Kugler. And now they're also rounding and supporting the age-friendly care, which has really been transformative, I think, at Center Care. Next slide. So initially, for the 230, we were taking 17 clinical groups, or there were 17 clinical groups for the nursing 230 with 8 students per group. And 15 of those groups were going to Center Care. And then 2 others went to a different nursing home, Juniper, which is now part of the collaborative as well. And we'll be working with them again this spring. Again, Andrew always does the orientation for the students. Donna and Marie were gracious enough to go in and help guest lecture to the students in the didactic portion of the course. And they focused on dementia and care of the older adult in nursing homes. And then they were also assigned age-friendly care clinical assignment. And for this group, we really just focused on mobility and what matters, because they haven't had pharmacology yet, and they haven't had any med-surg classes. So we really just wanted to kind of meet the students where they were. Next slide. Here's the clinical assignment sheet that Marie Yoder and I co-developed. And we are going to tweak this again because some feedback that we got was it needed to be a little bit simpler for the students, and they just, need to be able to take it and run with it. Initially, I provided the CATS Index of Independence for ADLs and the positive physical approaches to someone with dementia. And I think it ended up being like 4 or 5 different sheets. And so Maria's working to simplify that for the students this spring. And again, we're always trying to get better because the goal is to really make this opportunity in the nursing homes as positive as possible for the students so that they do, that they could see themselves potentially working here someday. Next slide. And so we did get some student reflections after they completed that clinical assignment. And some of the things that they talked about with the what matters to older adults and some of the themes that came through is caring about others, and that the older adult really cares about their family and their well-being, of their friends and family and their pets. They really were focused on maintaining independence and improving their function. And they were always looking for opportunities for socialization, to engage with others, especially around areas of interest. And some of the assumptions that students made, they were asked to list some assumptions. And one student said, never make assumptions, which I loved that answer. But older adults, one assumption student had, or several students had, was that they'd be unfriendly. And a quote was that he was very optimistic and enjoyable to talk to. And so again, that's, demonstrating to the student that we want them to see that they're able or could potentially work in a place like this and feel very comfortable and, make it an enjoyable opportunity. Another assumption was older adults need a lot of assistance. And the student said, he didn't. He scored very well on his catch, which surprised the student. A few students talked about their older adults, that they wouldn't have any emotion. And the one student's quote said, I just didn't expect to see him show this level of emotion. And it warmed my heart that I got to see this emotional side of him. And he was very grateful that the students were coming in and expressed that to the student, which I think, it definitely warmed the student's heart, but it also warmed mine as well. Next slide. And then other reflections that we got were some lessons learned. And the students, I think every single student that responded to that said that communication was the most important thing. And it wasn't just communication with the residents, but with the nurses, and being able to ask for help and incorporating things that the resident likes into their care. And so, this isn't probably new to anybody else, but to reinforce that to a student the very first time they have a clinical, how important communication is, I think is, a great benefit to the students. And then another student also said to never make assumptions. That was one of the lessons they learned. So it was interesting that 2 different students talked about not making assumptions about older adults. Another question that they were asked is to discuss similarities in the what matters, because not only was the student prompted to ask the older adult what mattered to them, in their reflection afterwards, they were to write what mattered to the student. And so some of the similarities were our love of family and animals, and which this kind of made me tear up, but the students said that they wanted the best for the residents and the residents wanted the best for themselves. And so to have students show that kind of empathy and compassion was really, I thought, very touching. And then differences, one of the things that the students talked about was, future looking and wanting to graduate, get a good job and have a happy family, where the residents kind of were reflecting on their careers and their legacy that they're leaving behind. And so that was interesting to see. Next slide. And then the other course that we worked on was 310. And again, very similar things that we did in 230. Marie Boltz and Donna Fick were gracious enough to go in and do some guest lecturing. The students also did the age-friendly care PA. We only have half as many students in nursing 310 as we do in 230, because the other half goes to Hershey. So we only had 9 clinical groups. They were all at center care. And again, Andrew Noggle gives the orientation, which, I mean, if you think about him doing 15 groups in the spring and 9 groups each fall. That's pretty time intensive, but I think it's a great asset. And then the age-friendly care clinical assignment they did, I'll show you in a minute, but it was the 4Ms worksheet. And then this level of students, they rounded with the LPN and the CNA and also the restorative team at times. So they could kind of see that collaborative nursing. And this group already did have pharmacology, and they're also taking a med surg class at the same time. So they were able to kind of go to the next level with their clinical expectations. Next slide. Here's our students working on their 4Ms worksheet, and you can see the resident engaged and kind of sharing her thoughts. Next. And here is the 4Ms worksheet. Again, this is a resource that's available through Age-Friendly Care PA modules, as well as the Teaching Nursing Home Collaborative. And it looks at the 4Ms. Yeah, I know Jenny kind of talked about this already. And so it really just focuses on the 4Ms, and you're able to complete it. And Center Cares really used this once the students started using it and demonstrating the positive things that can happen through the 4Ms worksheet. Next slide. Additional things that happened as part of the collaborative. They had a resident that had some challenging behaviors, and there was an incident, and the staff there was very concerned and reached out to Donna, and they were able to review the case and were able to make some significant positive changes related to practice and their procedures at Center Care, because they were able to talk through what happened, what could have happened, ways to react, systems to put in place. And so during this case study, it was Donna Fick was present. Again, that's kind of showing how we can maximize this collaboration and using expertise from the academic partners. But Center Care's team included the nurse practitioner Z, the medical director, Dr. Shannon, the director of nursing, and the recreational therapist. And so again, it changes practice. So yes, it will be beneficial for this particular resident in the future, but any resident that would maybe have a similar situation occur, that, things won't escalate as they did. So that's really positive. Next slide. The other thing, this is, I'm really excited about the student piece of it, but this is probably the thing that is really, impacting the residents directly the most. And they started using the 4Ms worksheet to round. So, and then when the doctor rounds at their quarterly assessments if you're familiar with long-term care, the residents have to be assessed by a physician or mid-level provider every 4 months. And so they incorporate the 4Ms worksheet with these quarterly roundings, and they were able to accomplish a lot. So either Felicia, who is in the bottom left corner, she is the assistant administrator, or the LPN that rounds with the medical director in the NP, will complete the worksheet ahead of time, and they'll kind of identify what needs to be discussed specifically related to that resident during rounding. And so if, we need PT there, recreational therapy, dietary, those people will come to that specific round. And we haven't been able to get the whole team together for all the patients yet, but I think this is progress. And so as a result, the patient's progress notes are following the 4Ms, and it specifically says this is related to age-friendly care health systems, and this progress note will follow the 4Ms framework, and they list it according to that. They still touch on every single thing a progress note should touch on, but it's all highlighted around the 4Ms, which is, I think, really beneficial. And just in the deprescribing alone, they were able to get rid of, more than 10 medications on several residents. And it's been 2 months, and the residents are doing very well. And this was all because of the 4Ms worksheet and this new rounding. Next slide. So we also, when we started doing the rounding, we talked to the residents and explained to them, what we were going to be doing. And as I mentioned, the progress notes are reading very, very much, or aligning very much with the 4Ms. And so if in this particular case, a resident had a chief complaint that was under that particular title, they said it was seen and evaluated her for follow-up multidisciplinary team approach to age-friendly care and 4Ms discussion, and that's sort of how the note starts. And then when they do the reviews of systems, it begins with discussed with resident today what matters most, medications, mentation, and mobility. And then the documentation that follows aligns with that as well. Next slide. And I'm not going to go through all this because I think we're running out of time and need some time for question, but we did do focus groups with residents and families, center care administration and staff, the PSU faculty and students, and we also are collecting data from the students and faculty at the beginning and end of every semester to see how the Teaching Nursing Home Collaborative is going, and to see, if we're making strides with getting students excited about working in nursing homes. Next slide. These are just some quick focus group results that we had related to the what matters. And these are from the residents' perspective, and the residents want to feel cared about. They want staff to understand what it's like to live with a disability, and they want to feel listened to. And they desire for staff to focus on the care they are giving residents. For mobility, the residents want to stay mobile. They wanted to encourage others to be mobile. They want to maintain a positive attitude and set goals that they can achieve. For medications, residents want to know what medications they're on, the indications, and any medication changes that are occurring. They also had concerns about medications being prescribed by multiple doctors. And so that was definitely a concern of theirs. And they wanted to make sure that the medication was needed. And so I think with using the 4Ms worksheet, they were able to do a lot of deprescribing on the residents that they rounded on. Next slide. And the final comments that they gave about receiving good care, that they were really encouraged by the students being there. They said that the students were open and friendly, and residents feel cared about when students are open and friendly. And then knowing people care about them when the students were there, they said that they knew that the students thought that they were good people, and that they can do this and do it. And I'll just read the quote exactly. It says, "Hey, you're a good person. You can do this and you can do that." Meaning that the students encouraged them to do stuff and knew that they were able, they were still a good person. They still had value, and that they were able to, in this particular case, it was get up and move more and walk. Next slide. And this is from some of the one quote is from a staff member and the other one is from a resident, but the CNA said, when students work with the residents, they get extra one-on-one time, conversation, activity, companionship. It's very helpful. And then one of the residents said, it made me really think about what was important to me. It was a lot of questions about the same thing. What is important to me, but I haven't thought about that really thought. What does matter to me? Now I wonder what is important and can that happen? And so I talked about that a little bit earlier, but the resident was really excited that we were focusing on what matters to the residents as part of this project. Next slide. This is just more about the rounding and some of the feedback we received related to the 4Ms. And I'll just focus on one. I think we share these slides with you so you can read them, but polypharmacy was probably the biggest one that I think the medical director and the nurse practitioner were surprised by. And when talking to Z, she said, I knew polypharmacy was important before, but I never really took the time to review it. And now I am trying to do a much better job at this. And the 4Ms worksheet has really helped her kind of convert to that. And so they were able to get rid of a lot of medications that were unnecessary. Next slide. So for your takeaways, I think the most important thing, whether you're a nursing facility or a school of nursing, or faculty at Penn State here is, if you're looking to implement the 4Ms, just start. One of the free things you can do if you're not really that familiar with age-friendly care health systems is you can get online and get free continuing ed credits and take the age-friendly care PA modules. But the idea is just to start thinking about how you can put this into your practice. Next slide. And this is just a quick little table that looks at each of the 4Ms. And the initial one is things you can assess. So, asking what matters, reviewing the medications, looking at their mentation and mobility. And then the second column looks at how you can act on those. And so if you ask somebody what matters, make sure you align the what matters with their care plan. For medications, if you're taking time to review and assess, make sure that you focus on deprescribing, especially those high-risk medications. If you're assessing fermentation, think about referrals, think about other things that affect cognition like sleep interruptions, or that can be a potential concern for delirium, such as hydration, infection. And then for mobility, if you're going to screen for it, consider taking the extra step to do something. So making sure their personal adaptive equipment is always available. And even things like if they can walk, instead of pushing their wheelchair to the bathroom, maybe push it to the doorway and let them get those few extra steps in. And so those are just some practical assessment pieces that you can act on. And next slide. And I think we're done if anybody has any questions.
Well, thank you so much to both of you. I really appreciate both of your perspectives from both the primary care and the long-term care setting. So multiple different perspectives, not only that, but kind of highlighting also like the big picture in terms of creating programs and partnering with organizations, but even the small, like little pieces of implementing age-friendly care into practice. So thank you so much. I think we have a few questions coming in.
A lot of great comments. So thank you so much, Jenny and Aaron, just echoing that. One person asked something I think is pretty practical, and maybe you can offer some insights based on some of the outcomes that you saw at Center Care. And they said, as a member of this population, I deal with peers who are family members, typically a spouse or partner, who are exhausted trying to meet needs, but they are also dealing with guilt due to not being able to meet the needs, or dealing with feelings that might need help and thus not seeking help. Is there anything that you might offer this person who's attending today that you think might help them in that situation?
You're on mute, Aaron.
Sorry, I keep doing that. But one of the first things that they could do is for caregivers, there's the age-friendly care PA modules for caregivers. And so just taking that and looking at that, they might pick up some important information that might be helpful. And then, thinking about they could, pull that worksheet and look at the, reviewing that with their loved one and thinking about really what matters to their loved one, and framing all of their care. And even if you're the caregiver, advocating for the what matters for your loved one. And I don't know if that alleviates guilt necessarily, but if you know that what you're doing or striving for aligns with what matters most to your loved one, then I think everybody's happier. And so that's just 2 quick suggestions. I hope that is helpful.
Oh, one other, I think a lot of the local facilities are also, and I'm sorry, I don't remember if the older adult was in a facility or not, but there are a lot of family groups that can meet, or councils, they sometimes call it. And sometimes just knowing that you're not alone, you're not the only person in that situation where you're providing care, but you're feeling guilt, or you're not able to provide as much care, but you're feeling guilty. I know just knowing you're not alone and other people are in that boat can really be a great way to talk about some of the concerns and problems. And I also know if you're facility doesn't have a family council, I know a lot of them kind of got put on the back burner during COVID, and some of them still haven't been brought back. Talk to the administrator, because I know they want to provide this support to families.
Those are great points. Thank you both. One question I guess I have for those, we have a lot of different people in our audience, but for maybe facilities that aren't quite as familiar with the 4 M's, how could they go about, if you have any tips or kind of where to start, if they want to get this age-friendly care or age-friendly community designation, where can they start to start implementing the 4 M's into their facility?
I'll take this. So IHI has a really great web page on how to start the recognition process. So it is a 2-part process. You can be level 1 recognized by just identifying that you want to make a difference and identifying the ways you're going to make a difference in your community assessing and acting on each of the M's. And then there's the level 2 recognition, where you actually have 3 months of data showing that you are assessing each of the M's. But IHI's webpage is a great resource to go through, and the way that you would submit the information is all right on the webpage. It's really an easy 1.5-page sheet that you would fill out about your community, and you could be recognized. And I'd be happy to help. So if you're a facility interested, let me know. I have helped a few other communities.
And the other thing I'll just add on to that is the Teaching Nursing Home Collaborative is enrolling all nursing homes in Pennsylvania. So if you're a nursing facility in Pennsylvania, you can join the Teaching Nursing Home Collaborative. And then the goal is that they partner you with an academic partner, such as Penn State. Depending on where you're located, they try to find the closest school or college of nursing. And so, there's that opportunity as well. And I think Donna put it in the chat. So if you look for Donna Fick's name, she has the link there to join the Teaching Nursing Home Collaborative.
Great. Thank you both for that education information. And thanks to Donna and Amy for putting both of those links in the chat. And for those on also, the email that you'll get within 24 hours also has both Jenny and Aaron's emails in it. So if you do want to follow up with them, you'll have access to their emails. Let's see. So we have a lot of, I'm sure you guys can see a lot of thanks and appreciation in the chat. A lot of comments about just the feedback from the staff and the students, just kind of hearing those personalized experiences, how important it is to give voices to the students and the feedback from the residents about how impactful the 4 M's have been to them. I'm just curious as we kind of wait for more, if there's any more questions. It's 12:59, so I guess we might close the session here to give everybody a chance to complete the evaluation. That went by too quickly. So thank you both for your expertise and for your wonderful presentation. And for those who are on, the survey link will pop up in your browser once I end the session. You'll get an email within 24 hours. And we are working on our spring 2025 seminar lineup, so stay tuned for that. But thank you both.